Hey, thanks for choosing BrainWaves. After the episode, take a look at our iTunes archive for other great content, and check out our new website at brainwaves.me. Now, on to the show.
Welcome to BrainWaves Briefs. This is our first episode of Briefs, actually. I'm Jim Siegler, and I'll be your host today. BrainWaves Briefs are audio podcasts that are designed to be helpful on your boards, on rounds, and on shelf exams for students. And today we'll be talking about foot drop. A brief word before we get started about anatomy. Remember that first time in medical school when you were evaluating your cadaver in lab and you learned that the peroneal nerve originates from the L4 to S1 roots and it merges to form the sciatic nerve. Here it dives through the greater sciatic foramen along with about 6 other nerves, notably the superior and inferior gluteal nerve, the pudendal, and nerves to the quadrator femoris and obturator internus. That's about all we're going to talk about as far as anatomy. Let's talk about the clinical scenarios. There's one interesting scenario that you can see with injuries that are proximal to the common peroneal nerve. Before the nerve reaches the fibular head, the peroneal division of the sciatic gives off one motor and one sensory branch. The motor branch actually innervates the short head of the biceps femoris and is the only muscle innervated by the common peroneal nerve above the fibular neck. I can't stress this enough. You will be asked about this on your EMG rotations, so don't muck it up. So remember, the peroneal division innervates the short head of the biceps femoris before crossing the fibular head. Therefore, if you were thinking of taking a patient history and found that they had a foot drop due to injury at the knee, you could confirm this with needle EMG of the short head of the biceps. Without any biceps denervation, the injury is going to be at the fibular head. Less clinically and electrographically relevant is the lateral cutaneous nerve of the knee, which supplies the upper and lateral aspect of the leg. If the lateral aspect of the leg has sensory loss, you should expect a common peroneal injury above the fibular head. But if only the lower lateral aspect of the leg has sensory loss, then that could be consistent with a superficial peroneal nerve injury, again at the fibular head. At the popliteal fossa, the common peroneal nerve branches into its deep and superficial components. The deep peroneal innervates the EDB and the tibialis anterior. In contrast, the superficial peroneal nerve innervates the ankle everters, notably the peroneus longus and brevis. The way I remember this is that the superficial peroneal nerve courses more laterally and therefore drives ankle movements more laterally. The deep peroneal nerve, in contrast, rides along the anterior surface of the tibia and assists with dorsiflexion. It supplies cutaneous innervation to that tiny space between the first and second toes that I'm sure all of you test on your routine clinical assessments. In contrast, the superficial peroneal nerve innervates the remaining dorsolateral area of the leg and the foot, except that tiny web between the first and second toes. Now let's talk about the clinical relevance. Patients with a peroneal neuropathy typically have a lesion in one of 2 or maybe even 3 places. If the lesion can occur at the hip, then the lateral fibers of the sciatic nerve are most susceptible to injury. These lateral fibers eventually make up the peroneal division, whereas the more medial fibers comprise the tibial division. If the lesion occurs at the fibular head, the patient walks with what's called a steppage gait, meaning they raise their affected leg a little bit higher with each step to compensate for the foot drop. And you can also confirm fibular head injuries by testing for a Tinel sign. You do this by tapping on the lateral head of the fibula to reproduce dysesthesias of the lower lateral calf, as you would in a patient with carpal tunnel syndrome. Thirdly, and quite rarely actually, a lesion could occur at the ankle, and this is called anterior tarsal tunnel syndrome. This is a deep peroneal neuropathy that presents as paresthesias of, again, that tiny little space between the first and second toes, as well as EDB dysfunction, resulting in extensor weakness of the first 4 toes. One major clinical dilemma is having to make a distinction between a peroneal neuropathy and an L5 radiculopathy. Most physicians remember this distinction by assessing for ankle inversion. Now, this isn't just asking your patient to bend your ankle inward. You should start to test for inversion strength by passively dorsiflexing the ankle and then asking the patient to push inward in order to isolate muscles of inversion, notably the tibialis posterior, which is a muscle group supplied by the tibial nerve, an L5 root. There's also a subtle difference in weakness between 2 peroneal innervated muscles in the case of an L5 radiculopathy, the EHL, which is predominantly L5 innervated, and the TA, which is L4 and L5 innervated. Sometimes you can see weakness more so in the EHL, so extensors of the big toe, than with extension of toes 1 through 4, which would indicate an L5 radiculopathy more so than a peroneal neuropathy. You can also test the tensor fascia lata, which is a hip abductor and a predominantly L5 innervated muscle group, so there would be weakness of the hip at that point. That about covers it for this BrainWaves brief. In summary, foot drop occurs from an L5 radiculopathy, sciatic neuropathy from compression around the hip, superficial injury at the fibular head, or at the ankle joint via compression through the inferior extensor retinaculum. Distinguish your peroneal neuropathies from L5 radiculopathies by testing for ankle inversion, which is a tibialis posterior process, as well as hip abduction due to weakness of the extensor fascia lata. Unfortunately, we didn't have enough time to talk about a lumbosacral plexopathy, but keep that in mind as well. See you next time.
If you like what you just heard, you can find more related material on Twitter at BrainWaves Audio or contact us at bweditorialboard@gmail.com. Be sure to check out our iTunes archive for older episodes. This episode was produced by Jim Siegler. Music by Andy Cohen. This episode was sponsored by Smiling. Set your teeth free. Please join us next time for another edition of BrainWaves.